Already.
Okay, just
You can start, sir. Thank you.
okay. Good evening, colleagues. Welcome to our discussion session again today. I'm doing this with Dr. Sawa, but I saw this document today, and I just felt it would be interesting to share. Actually saw it just like 2 hours ago when I was just searching the net, and it's on the 10 commandments for the 2023 ESC guidelines for the management of acute coronary syndrome. So there are 10 items they brought out strongly as commandments, so to say. So commandment 1 talks about that acute coronary syndrome should be considered as a clinical spectrum. So it's a spectrum encompassing unstable angina, end-STEMI, and STEMI. And they said, while there are some differences in the timing of invasive strategies, the basic principles underpinning the assessment, diagnosis, and management of ACS are similar for all three acute coronary syndrome subtypes. Okay. Then the second commandment says, think, acts, ACS. A is actually when you have an abnormal ECG, which is suggestive of an ischemic process. Then C is you look at the clinical context or the presentation of the patient. Then for S, you now try to find out if the patient is hemodynamically stable or unstable. So commandment 2 says we should think, acts, ACS, when initially assessing patients presenting with suspected acute coronary syndrome. This involves performing an ECG to assess for electrocardiographic evidence of ischemia, that's the abnormal ECG, which is the A, considering the clinical context of the patient's presentation, including presenting symptoms, the results of any available investigations, and the clinical background, and performing a focused clinical examination to assess if the patient is clinically stable. So that's the ACS. Then commandment 3 says invasive coronary angiography during the index hospitalization is generally recommended for patients with ACS. A key component of ACS care pathway is identifying patients who require immediate invasive coronary angiography and revascularization, including patients presenting with STEMI and end-STEMI with very high-risk features like those that are hemodynamic, unstable, cardiogenic shock, with recurrent or ongoing chest pain that is refractory to medical treatment, in acute heart failure, presumed secondary to ongoing myocardial ischemia, life-threatening arrhythmias or cardiac arrest after presentation, mechanical complications, and recurrent dynamic ECG changes suggestive of ischemia. All that description is just for very high-risk end-STEMI patients. So invasive coronary angiography is recommended for such patients. Then invasive coronary angiography within 24 hours of admission should be considered for end-STEMI patients with high-risk features. Confirmed diagnosis of end-STEMI as per the European Society of Cardiology algorithm, the GRACE score, which talks about the disposition of the ACS, and GRACE score of 140 is high risk. Transient ST segment elevation or dynamic ST T wave changes. So commandment 4, for patients who are not presenting with STEMI or end-STEMI with an indication for immediate invasive coronary angiography, an algorithmic approach using the ESC 0/1 or 0/2H algorithm should be used to rule out the end-STEMI as in 1 hour, 2 hours check of biomarkers. Then for Commandment 5, all patients with a diagnosis of acute coronary syndrome are recommended to be treated initially with a combination of antiplatelet and parenteral anticoagulation. While anticoagulation does not need to be continued beyond the acute hospitalization phase in patients without a separate indication for long-term oral anticoagulation, oral antiplatelet therapy is recommended to be continued beyond the acute hospitalization phase in all ACS patients. Commandment 6, dual antiplatelet therapy consisting of aspirin and a P2Y12 receptor inhibitor, preferably one of the potent P2Y12 receptor inhibitors, prasugrel or ticagrelor, for 12 months, remain the default recommended dual antiplatelet therapy regimen for patients with a diagnosis of ACS. However, this 12-month default duration of dual antiplatelet therapy can be abbreviated or prolonged depending on the clinical situation and bleeding risk of the patients. Commandment 7, complete revascularization via PCI or CABG is generally recommended for patients with ACS, although the timing and guidance of this can vary slightly depending on the clinical presentation. Then Commandment 8, all patients presenting with ACS require aggressive secondary prevention to prevent their risk of recurrent events. Prevention of the next cardiovascular event begins at the time of the ACS diagnosis. Commandment 9, all patients with ACS should be discharged on cardioprotective medications with information on lifestyle management, a referral to cardiac rehabilitation, and a follow-up outpatient appointment. The treatment goals at outpatient follow-up should be to support healthy lifestyle choices, to promote adherence to and persist with pharmacological cardioprotective therapies, and to reach and sustain risk factor treatment targets. Key treatment targets for patients with ACS include a blood pressure of less than 130 millimeter mercury systolic and 80 millimeter mercury diastolic, LDL cholesterol of less than 1.4 millimole per liter, which is 55 milligram per dl, and for diabetic patients, HbA1c of less than 53 millimole, less than 7%. And the last commandment, which is Commandment 10, now talks about the care of patients presenting with ACS should not only reflect the best scientific evidence, but should also try to promote care that is respectful of, responsive to the individual patient's preferences, needs, and values. These should be applied to all patients for the care of patients with, for all aspects, this should be applied to all aspects of the care of patients with ACS, from the initial presentation throughout the hospital inpatient journey, extending through to long-term outpatient follow-up. So I'll just go up a bit now. Maybe this picture or this will help us recall much of what is said in the 2023 commandment for acute coronary syndrome. So if we look up here, we'll see that from the very first commandment, acute coronary syndrome should be considered as a clinical spectrum. So it's a spectrum from unstable angina to end-STEMI and even to STEMI, right? And then the next thing they said, we say we should think acts at the initial assessment of such patients. ACS means, the A means the abnormal ECG finding. Okay. Abnormal as ECG evidence of ischemia, which is the A. Then the C is we look out for the clinical context of the patient's presentation, right? So we look out for what are the presenting symptoms, okay? Do they have any results of maybe any investigations they are coming with? And then what is the clinical background? That is important to look at this step one. And then the other thing we want to look out for is whether the patient is clinically stable. This is very key and determines what we do next. From step two, you immediately start thinking about invasive management. As long as you're now saying this is acute coronary syndrome, you start thinking of invasive, uh, you start thinking of invasive management. Like if it is STEMI, we are thinking of a primary PCI or fibrinolysis if timely primary PCI is not feasible, okay? Then the other aspect is for very high risk NSTEMI and high risk NSTEMI. So for very high risk, you want to do an immediate angiography with or without a PCI. Then for the high risk NSTEMI, we want to do angiography in them. That's class 1, actually. That's one evidence. Then the next thing is, first you think initial assessment, second you think invasive management. The next thing is to think about antithrombotic therapy, okay? And as we saw earlier that antithrombotic therapy in them involves dual antiplatelet therapy consisting of aspirin and a P2Y12 receptor inhibitor, okay? And preferably one that is potent, that's use of either prasugrel or ticagrelor. But when they are not available, of course, we can use clopidogrel. So, but the thing is, in combination, antithrombotic therapy, that's antiplatelets and anticoagulant therapy. So aspirin and a P2Y12 inhibitor is what is recommended, either using prasugrel or ticagrelor. And then the recommendation is that this should be for 12 months. That's the default recommended regimen for patients that have a diagnosis of ACS. Okay, however, this could be shortened or prolonged. It also depends on the patient's, bleeding risk. Patient's bleeding risk is important to look out for. So we'll not just continue dual antiplatelets indefinitely. We'll keep accessing to check for bleeding risk. And then the other aspect is use of anticoagulation, unfractionated heparin, low molecular weight, either of all this. And we know before we can do any revascularization or invasive procedure as such, and these are therapies the patients will need to be on. Okay, so the next thing is to think revascularization. Now, based on the clinical status, is this patient hemodynamic stable or not? And then are there comorbidities, for example, in a diabetic patient, where you know that the likelihood is a multi-vessel disease. So that will determine whether we're doing PCI or CABG. Okay, and then the complexity of the disease the patient presents with. Okay, and then the aim should be for complete revascularization. And then we should consider adjunctive tests to guide revascularization, like intravascular imaging and looking at intravascular physiology. Then the other aspect, which is the last, is to think secondary prevention. Secondary prevention, like we highlighted earlier, that actually secondary prevention should commence, it should begin at the time that the diagnosis of ACS is made. Okay, secondary prevention starts from that time the diagnosis of ACS is made. And what does this involve? The antithrombotic therapy, use of statins, cessation of smoking, cardiac rehabilitation, risk factor management, and psychosocial considerations. Okay, so what are the 5 key things? Just summarizing this slide now. We should always remember that it's a spectrum from unstable angina down to end-STEMI and then to STEMI. And then we should think ACS at the initial point. ECG, clinical context, stability of patients. Then the next thing, once we know this is ACS, we should think of an invasive management, and then think of antithrombotic therapy using dual antiplatelet therapy and anticoagulants. Then think revascularization, which should be early, which should be also complete. And then we should think of secondary prevention, even from the point when we make this diagnosis. So in terms of anticoagulation use for STEMI, unfractionated heparin is at class 1 level of evidence, okay? And then, of course, patients with STEMI are the ones who should have primary PCI done. So anticoagulation therapy is very important in them. So the class of evidence is just below here. So, but unfractionated heparin is class 1, enoxaparin is class 2A, evalirudin is class 2A, fondaparinux class 3, and then for end-STEMI, angiography is recommended. So if this is done in less than 24 hours, the anticoagulant that is at class 1 is the unfractionated heparin, while the others are 2A, and then fondaparinux is class 1. That is if the angiography is done after 24 hours. So fondaparinux is at class 1 level. Then the use of routine antiplatelet pre-treatment, aspirin is at class 1. Then the P2Y12 inhibitor 2A, and then for end-STEMI, P2Y12 inhibitor is class 3. Then as per choice of P2Y12 inhibitor, prasugrel, ticagrelor, they top the chart. And if prasugrel and ticagrelor are unavailable, or if they're contraindicated or cannot be tolerated, then we can use clopidogrel. This is class 1 level evidence. So proceeding to PCI, prasugrel favored over ticagrelor. That's class 2A level evidence. Then for the default dual antiplatelet therapy strategy for first 12 months, we use the aspirin and a P2Y12. This is class 1 level of evidence. And like we said earlier on, it can be shortened or even prolonged in terms of the use. But what is important is looking out for bleeding risk in these patients. So you can have for 12 months, and then you can go beyond 12 months use of aspirin. This is class 1 level. So I just felt maybe I just saw this document and I felt as we talk about the guidelines in ACS, this would help to just recall the 10 commandments. Thank you very much.
Thank you so much, Chief Itubi, for taking us through these 10 commandments and for that pictorial diagram too. We really, really appreciate you. Chief Sawa, I don't know whether there are additional comments or if Chief Sawa is ready.
Okay, thank you very much, Chief Itubi. It feels like you've taken the burden completely off my shoulders, because this is almost entirely everything we are going to talk about. So at the end, I was even feeling like, is it even necessary for us to still talk about the guidelines in detail? Because this is an excellent overview of what we're actually going to be looking at. It's a summary of everything in that document, actually. So I don't know, do we still proceed nevertheless? By the way, I'm still trying to get my laptop on. I don't know why it's refusing to log on. I've just restarted. I hope it's okay.
Okay,
It's
sir.
coming.
Okay. Thank you, everyone. Maybe I'm
Okay.
thinking if we look at the guideline, maybe to reinforce some of these things.
Yes, I also think so that we should still look at the guidelines. So you know, this is a summary. There might be one or two things that we can still gain from it. So.
Okay. Thank you, Dr. Etubi. I don't know. My own laptop is on. I don't know if I can share slides and take the early parts of the heart failure guideline.
Please kindly wait. Kindly wait, Dr. Maladi. Chief Tower, are you ready to just buttress what Dr. Etubi has said, please? So that I won't be going from one to another.
Laptop is not coming home yet.
Oh, I can put that you have
It's
connected both.
connected.
Okay.
So you have connected both.
Please stop sharing it so that's okay.
Okay, it's because they are connected, but so that we'll just not be. We'll have something to not so that we'll not just be going from one topic to the other. That's why I said that. Dr. Sawa, I don't know. I've canceled that you've connected your laptop.
Yeah.
Okay, you have to mute one device, sir. The echo is coming from you, sir. So once you are ready, Chief Sawa, you can start. Then Dr. Umuradi and Dr. Ruki. Thank you very much. It's okay, we understand, sir. Thank you.
No, I think even the laptop is beginning to misbehave in protest of overuse.
The laptop should just calm down. We're almost there.
All right,
Alex,
so
it's too much jacking that is making
crashing.
it's too much jacking. He's disturbing the laptop.
Let the laptop do this exam because we can see your screen, sir. Thank you.
The laptop that is not being disturbed.
Okay. I think we are set to go now. Good evening again, everyone. And a follow-up kind of reinforcement to the initial 10 commandments we received from Chief Etubi, straight from Mount Sinai. I would want to be talking about this ESC guidelines a little bit more detailed than he did, but I don't think it's going to be in full because this is a 107-page document. So are we looking at the important highlights? Hello? You see, okay, good. It's up now. Yes, so this is just like a kind of summary of the entire document. I'm not going to dwell heavily on it because Chief Etubi has actually spoken extensively about it. It's a kind of summary about everything this guideline is talking about. So when compared to the previous guidelines of acute coronary syndrome, I think the modification this had is that they considered ACS as a spectrum. So this document is all encompassing. It's dealt with all the acute coronary syndrome, starting from unstable angina to STEMI. unlike previous document where you have a separate guideline dealing with unstable angina, they went ahead, they had a separate guideline for NSTEMI and a separate guideline for STEMI. So this, at this point, is almost more like a unification of all the whole guidelines in one. And they considered the evolution of acute coronary syndrome as a spectrum that spans from unstable angina down to stable and to STEMI. So first commandment, meet a patient who is at risk and he has symptoms that is suggestive of acute coronary syndrome. What the guideline says is we should think ACS. ACS is an acronym. A stands for abnormal ECGs. C, you look at the clinical context. And S, you look at the stability of the patient. So these first three steps forms like the three main pillars that the subsequent actions you're going to take is going to depend upon. So when you do ECG, and you find ECG that's suggestive, and you look at the clinical context, you see that it is also a high-risk situation, or there is that particular risk that the patient might likely actually be having an acute coronary syndrome. The next thing you're going to be looking at is whether or not this patient is stable and what is the next step you're actually going to take. So depending on what you find on ECG, whether you find a STEMI or a non-STEMI, the recommendation here is you should always think invasive. That is for them anyway, but that is the ideal. For us down here in this part of the world, we might actually probably be stuck to fibrinolysis. The invasive aspect, I think, is gradually, but we are going to get there. But as a cardiologist operating by standard guidelines, first thing you see a patient, acute coronary syndrome or invasive management. So if you have a STEMI, primary PCI, if PCI is possible, or if it is not possible, try to institute initial fibrinolysis and make an attempt to transfer to a PCI capable center to achieve that primary PCI. On the other hand, if it is a high-risk non-STEMI, you try to see if you can in as fast as 24 hours, within 24 hours. Then that will now determine whether or not if it's actually an obstructive event you are looking at, then you intervene. Otherwise, you will begin to explore other alternative measures of management. Then a very high risk, you do an immediate angiography with or without PCI. At this point, what differs from very high risk and NSTEMI and the high risk is timing. But at the end of the day, you can agree with me that the ultimate goal for all of them in this point is that you want to go invasive. So after the invasive therapy, the next important thing we need to think about again is antithrombotic. Sorry about that. A call just came in and interrupted. Hello, am I audible? I just need a confirmation that I'm audible.
Yes, you're back.
Right.
Yeah.
Thank you very much. Okay, so these patients we know either you do an invasive management or you do the risk factor that predisposes them to development of an acute coronary syndrome will subsist. So afterwards, you will have to think about antithrombotic therapy, and this constitutes two things. Either you're doing a dual antiplatelet therapy and a triple antiplatelet triple therapy, which includes the use of coagulants. So the options we have in our inventory include aspirin, the P2Y12 inhibitors, that is for the antiplatelet therapies, and the anticoagulant, we have fractionated heparin, low molecular weight heparin, bivaluridine, or fandaparinol. So shortly, we shall look at situations. There are actually different scenarios, and that the guidelines recommend when to use and when not to use each of them. Okay, so subsequently, again, we'll be looking at the next thing you're going to be looking at is sterilization procedures, whether you're going to do a PCI or a CAPG, or you are going to just go ahead to do an intravascular imaging to confirm what next step you're going to take. But the ultimate thing is that we want to achieve complete revascularization. So if the patient smokes, you will want to achieve smoking cessation. Cardiac rehabilitation also is a very important component, then risk management and psychosocial considerations. One thing the ESC writers of this guideline actually pride themselves about is, I think this is one of the first few guidelines that the writing has actually incorporated the patients. I think some of the patients are part of these guidelines. So that is why this psychosocial consideration, I think, probably came in very high up here. So I don't know, is my voice still fluctuating? No?
No, sir, you're back, sir.
Okay, thank you. Sorry about that. All right, so again, I will be largely be looking at, I want us to go through most of those figures, those diagrams, because it's much easier to actually go through images. And we can look at 100 images faster than reading a picture. So I will want to be using those. They have very beautiful illustrations that actually summarize the main and key messages. So possible clinical scenarios where a patient might present with pain that is suggestive of acute coronary syndrome. One, it's either the patient might have very few symptoms, or sometimes they might even be asymptomatic, particularly if you look at the case of, they said in women, probably again, maybe they are diabetic, so they might have silent MI. So this should actually make us to understand that it is possible, very possible, that the patient can have an acute coronary syndrome, yet the patient is not going to be having pain. So another context that is a possibility is that this chest pain that they have might actually be increasing, or it continues, or sometimes they might go into cardiogenic shock, or sometimes these are the multiple different scenarios that these patients are actually going to present. So when you find this kind of instance, and immediately you look at the clinical context, and you see that, yes, the possibility of an acute coronary syndrome actually subsists. The first thing we want to look at is quickly stick up an ECG, do an ECG, and confirm. The possibility things you're going to get is either you get the ECG to be normal, there's ST segment depression, or you get an ST segment elevation, or you get malignant arrhythmias. Now, when you get ST segment elevation or malignant arrhythmias, by the time, in fact, it's the prognosis of the patient, they said, is even much better by the time you are seeing an obvious abnormality, rather than when you are seeing whether it is epivocal or it is almost looking like normal, because there are quite some instances where you are likely going to have an ongoing acute coronary syndrome, and yet ECGs are not going to be suggestive. So one important thing about this ECG that has not actually changed in these particular guidelines, or it has actually been sustained, is that this ECG is not going to be a one-off thing. It's a continuous process, because we know, this ECG changes in the context of myocardial infarction is an evolving dynamic thing. So it's an evolving thing. When probably maybe at that point you did not catch those changes, subsequently these changes are likely to appear. So based on the ECG, you're likely going to have possibilities of two diagnoses. One is either you think that maybe you're dealing with a non-ST segment elevation, ACS, or STEMI. Like I said, STEMI, the best. Not in terms of prognosis, and not in terms of the fact that maybe they will want to choose it or something, but in terms of the fact that it's a clear-cut diagnosis. You're not actually having any ambiguity, and you know straight on what to do and going on. You're not going to waste further time trying to establish exactly what the diagnosis is, as compared to if you're having a non-STEMI like acute coronary syndrome. So next thing is the laboratories. High sensitive cardiac troponin is what is recommended here. So two things you can either have, particularly in ST segment elevation, you can be non-elevated, or in STEMI, it is characteristically known to be having this pattern of rise and fall. So if you're having a rise and fall cardiac troponin, high sensitive cardiac troponins, then of course it's confirmatory of your diagnosis. So with all this initial assessment, it's going to help you to finally arrive at a diagnosis of either this patient is having an unstable angina along our spectrum of ACS that we have actually alluded to initially. So you make a diagnosis whether this patient is having unstable angina or an STEMI, or finally is having a STEMI. So this table here, just a quick rundown of it. I think it's just some few definition of terms that we should just quickly look at. The FMC is the first medical contact. We'll be seeing most of, we'll make a reference to that subsequently in some of those timings with respect to revascularization priorities for each of our patients. So it just simply says that it is that time when the patient has made that initial first contact with a medical facility or medical personnel. So it can either be the paramedics, it can be either in the hospital or at any point. But from that first point of contact with any medical or medication facility is what is referred to as first medical contact. STEMI diagnosis still remains the same based on ECG in appropriate context. Then primary PCI is actually the emergent primary percutaneous coronary intervention with either a balloon or a stent or other approved devices that is performed on the ischemic related artery without previous fibrinolytic therapy. Now, where this primary PCI, there's a primary PCI, then there's a secondary PCI. So you first do primary PCI when there's no any fibrinolytic or any other procedure that was done. Then rescue PCI, you do a rescue PCI in an emergent situation when a primary PCI has already been done or there's a failed thrombolytic attempt that was given to the patient. Okay, so pharmaco-invasive, immediate invasive strategy, early invasive, and selective invasive strategy. These are all different definitions of terms that I think is important for us to pay attention to. Okay, so again, this is just trying to summarize the initial algorithm that we have just walked through. You have a patient whose clinical presentation is actually suggestive, confirmed with ECG. You either get a STEMI or an STEMI. The next thing is you do a laboratories. By the time you confirm from your laboratory, the investigations, either cardiac troponins. If it's confirmatory for STEMI, you go ahead straight and do an angiography. There is also room, particularly in non-ST segment elevation, myocardial infarction. You can also do non-invasive imaging, such as echocardiography. So that will help you to make your final diagnosis and it will guide in your treatment. So, okay, this we will talk about it much later. So Okay, another thing I want us to talk about here, to look at briefly, is the triage and diagnosis of this patient. Okay, now this diagram, we're going to be seeing a lot of these basic repetitions of each of the steps. Okay, patient presented with appropriate or suggestive of ACS. The first thing I said we'll do is we'll do an ECG, do examination, take a brief clinical history, look at the vital signs, and get your troponins. Okay, by the time you do this from the ECG, it will tell you whether it is the STEMI, non-STEMI, non-ST segment elevation, ACS with very high risk features and without high risk features. So depending on what you get, if it is an if it is STEMI, it is recommended that you do an immediate angiography with or without your primary percutaneous coronary intervention. That is, this is when it's obtainable within the appropriate time. If it is not, you have to consider an immediate fibrinolysis and activate all the procedures and protocols to transfer the patient to a PCI enabled facility where you'll be able to get PCI within the appropriate prescribed timings that will guarantee maximum or best outcomes for the patient. Okay, so in case of NSTEMI without very high risk features, the option here is to consider angiography within 24 hours. While if it is NSTEMI with high risk features, the timing, like I said earlier, is what differentiates these two things. But at the end of the day, we're going to be looking at antithrombolytic therapy and PCI as our options for interventions. So your further investigations that you will need to do include an immediate angiography, echocardiography, mostly is transthoracic echocardiography. Then intravascular imaging also have a very good role here, your troponins and ECG monitoring. So further management includes PCI, CAPG, long-term medical therapy, lifestyle measures, and cessation of smoking. So this is, again, just largely a repetition of some of those steps that we've been actually talking about. So I want us to look at this recommendation for clinical and diagnostic tools for patients with suspected acute coronary syndrome. Now, it is said that it's recommended to base the diagnosis and initial short-term risk stratification of acute coronary syndrome on a combination of clinical history, symptoms, vital signs, and other physical findings that include ECG and high-sensitive cardiac troponins. So this is a class 1B recommendation. So basically, this is just kind of summarizing almost everything we've spoken about. You see a patient who you think have features or risk factors for ACS, think ACS. Next thing you want to do, look at the clinical context. If the clinical context fits in, you quickly do stick up an ECG, you check and see, as long as it's suggestive for you, the next thing you want to do is high sensitive cardiac troponins. Class 1B recommendation. Now the ECGs also have their own, so you need to do a 12-lead ECG. And the interpretation is recommended as soon as possible, which mostly is supposed to be at the point of first medical contact with a target of less than 10 minutes. So first medical contact, within 10 minutes, you're expected to get an ECG done and interpreted. Then you stick up ECG for continuous monitoring. The availability of defibrillator capacity is recommended as soon as possible in all patients with suspected STEMI. So an ECG changes or ongoing chest pain, and once the diagnosis of MI is made, you're going to need to activate the subsequent steps in managing this patient. And the use of these other ECG leads, such as the right-sided leads, is also recommended in cases of inferior STEMI. or if total vessel occlusion is suspected and standard leads are actually inconclusive. There are other situations where we call the STEMI mimics, okay, where particularly this inferior or posterior STEMI that you're likely going to get, and that will warrant you to do this right-sided ECG to quickly nail your diagnosis as far as ECG is concerned. Then an additional, this is also a class 1B recommendation. Then 1C recommendation says that an additional 12-lead ECG is recommended in cases with recurrent symptoms or when you are beginning to have some diagnostic uncertainty. Then these other ones are talking about blood sampling, where you take your blood samples. And also, I will want to talk about here, although I think Dr. Tubi has mentioned this, but for the sake of emphasis, now the high-sensitive cardiac troponin measurement is actually going to be done in a repeated. It's recommended that you do it in a repeated format. You take either you take at 0 hours, then you repeat at 1 hour, or you take at 0 hour and you repeat at 2 hours. Okay, so that is the recommended way in taking the blood samples for high sensitive cardiac troponin. So depending on what you see at that point, either a rise and fall or a normal, that you combine it with other your findings of either ECGs and other clinical contests, it's going to help you in making your diagnostic decisions. So the last one here is triage for emergency reperfusion. It's recommended that patients with suspected STEMI are immediately triaged for an emergency reperfusion strategy. So moving on, there's this rule in and rule out criteria also that is also very, very important here in this guideline. So first thing, you find a patient who you're suspecting he has STEMI, there's no indication for immediate invasive angiography. It is recommended that you take your high sensitive troponin, like we've mentioned, 2 samples. First one at 0 hours, the second one depending on your own discretion at that point. The other take at 1 hour or after 2 hours from the initial sample. So if your high sensitive cardiac troponin comes out to be low, or there is low initial high sensitive cardiac troponin and there's no increase in either 1 hour or 2 hours, this has a very high negative predictive value. So it helps you to rule out the possibility of an acute coronary syndrome. On the other hand, if you have a high initial high sensitive cardiac troponin, or there's an increase at either 1 or 2 hours, it also have a very high positive predictive value. It helps you to rule in the fact that, yes, there is a very, very high possibility that this patient is having acute coronary syndrome. The dilemma are those in between on defense. This category of patients do not meet the criteria for either of these other two, and own is ambiguous. It's neither here nor there. So at this point, what is recommended is that appropriate management can be determined based on these high sensitive troponin levels and clinical situation. And at this point, these are the kind of patients you need to monitor very closely and observe for any further changes. Okay, so the next table we want to look at here is this table 2, recommendation for non-invasive imaging in the initial assessment of patients with suspected acute coronary syndrome. Now, emergency transthoracic echocardiography is in patients with suspected ACS presenting with cardiogenic shock or suspected mechanical complications. This is a class 1C recommendation. So when you have a patient whom you suspect is having acute coronary syndrome and he has cardiogenic shock or is beginning to have some mechanical complications, emergency transthoracic echocardiography is recommended for quickly find out what exactly is the situation. Okay. That's the problem of using phones. Sorry, I just got a call. Am I audible? I need to confirm if I am before I proceed, please.
You are.
Okay. Now, in patients with suspected acute coronary syndrome, whether you are having non-elevated or is uncertain, that is with reference to your troponins now, and you don't have ECG changes, and there's no recurrence of pain, incorporating a coronary computed angiography or a non-invasive stress imaging test as part of the initial workup should be considered. Now, in these categories of patients, these are mostly those middle patients who you are not really too sure about their diagnosis. You cannot rule in, you cannot rule out. So it is suggested that you should consider, this is class 2A recommendation, by the way, you should consider a coronary CT angiography in these categories of patients. Then emergency transthoracic echocardiography should also be considered at the triage in cases of diagnostic uncertainty also. But this should not result in delays in order to transfer the patient to a cardiac catheterization lab if the suspicion that you are having for this ACS is actually very high. Now, one thing the recommendation here is it's recommended that routine CT angiography in patients with suspected acute coronary syndrome should not be done. Well, I find this to be a problem for them over there where most of these things are readily available. And for us here, I think even the cost alone and availability will not encourage us to be doing a routine CT angiography for most of these patients. But it's important for us to note that as part of these recommendations, it actually has a class 3 recommendation. So the next important point I want us to look at is recommendations for initial management of patients with acute coronary syndrome. This has largely not changed from previous guidelines. Oxygen therapy, particularly in patients who have saturation less than 90%. And it is also re-emphasized here that routine oxygen therapy is actually not recommended if these patients don't have oxemia, that is their saturation oxygen is greater than 90. So the use of opioids as pain relief and other appropriate management, beta blockers are also the same, just like we find in other previous guidelines. So I wouldn't want to dwell too much on that. Then the pre-hospital and logistic care is also all in place here to ensure optimal management of the patient before the patient is transferred to the hospital. So now, in transferring this patient to the hospital, they are likely going to encounter quite a number of logistic delays. So this diagram here, just trying to highlight some of those technical delays we can have in taking a patient who has acute coronary syndrome to the final point of care, which is ultimately to achieve total revascularization. So there's this total ischemic time, and this total ischemic time comprises of the time between there's the patient delay, and there's a delay also occur in the system, that's particularly probably in the hospital. And if this patient did not present directly to the health facility, probably in between there was an emergency medical service and an ambulance that actually pick up the patient. There's another component of that delay also that takes part of this patient delay, and sometimes it can also be incorporated to include it into the system delay that the patient has. So the ideal thing is, as much as possible, we should minimize this delay, either to minimize this total ischemic time. That has been found to improve outcomes significantly in the patient. So if this patient whom has developed an acute coronary syndrome actually presents directly to a PCI center, the aim is to achieve revascularization in less than 60 minutes. So that's here it's saying that's less than 60 minutes to wire crossing. So from the time of first medical contact, from the time of patient presentation to the facility, 60 minutes, within 60 minutes, we should be able to have passed our catheter and the patient and achieve revascularization in that patient. Now, if there was some delay that has taken out of this time, we have an additional 90 minutes. So in less than 90 minutes, and if this patient is presenting to a PCI capable center, in less than 90 minutes, we should achieve revascularization. However, if all these things are not possible, in less than 10 minutes, fibrinolysis should be instituted in these patients. So these are the timelines to minimize delays in most of these patients. So just look at this is guiding us through selection of appropriate invasive strategy. So if this patient has high risk, we've confirmed STEMI, whatever delay, the patient is already with you. The next thing you want to do to triage the patient is this patient actually a high risk? If it confirms that the patient is high risk, you're going to immediately do an invasive strategy, which is class 1, because we mentioned that. So what constitutes those high risks include either he has hemodynamic instability or cardiogenic shock, or there's recurrent or ongoing chest pain refractory to medical treatment, or there's acute heart failure presumed secondary to ongoing myocardial infarction. He has life-threatening arrhythmias, or there's cardiac arrest, or there's actually mechanical complications. Then some of them might have recurrent dynamic ECG changes that are suggestive of ongoing ischemia. These patients, in the presence of any of this, is considered as high risk and an immediate invasive strategy within the shortest possible time. Like we saw in the previous diagram, less than 60 minutes, we should achieve revascularization in that patient as a class 1 recommendation. Now, if the patient is high risk, don't forget this other one is very high risk. High risk, and we've confirmed the diagnosis of NSTEMI based on the ESC algorithm. At this point, this is where the GRACE risk score is being utilized here. So if the GRACE risk score is greater than 140, and there's transient ST segment elevation, or there's dynamic ST segment or T wave changes, these patients are considered as high risk. So early revascularization is recommended here. So within 24 hours is our timeline that we should be able to achieve our revascularization in this patient. And inpatient invasive strategy is also subsequently recommended for those patients. Then non-high risk patients, and in this patient, they are patients without very high or high risk features and a low index of suspicion for stable angina. You look for other alternative selective invasive strategies. But if they are non-high risk, you can transfer the patient if there's actually any need when they have some ambiguity. You're not really too sure, you've not really confirmed what the status of this patient. You can transfer them to other higher facilities where they will be able to look at other modalities like the CT angiography and confirm what the diagnosis of that patient is and what the appropriate therapy is going to be like. The next one, let's look at table 4. Recommendations for reperfusion therapy and timing of invasive strategy. Generally, this also has not really changed compared to the previous guidelines, but as part of 1A recommendation here, it said reperfusion therapy is recommended in all patients with a working diagnosis of STEMI, resistant ST segment elevations or its equivalent, and symptoms of ischemia of less than 12 hours duration. Also, a PCI strategy is recommended over fibrinolysis if the anticipated time from diagnosis to PCI is less than 120 minutes. So 2 hours from presentation, patient presentation, you can still go ahead and do a PCI if it is still possible. So not that we will say, okay, this patient has already passed the initial 60-minute time and you abandon. No, as long as there's a high possibility that this patient is having an acute coronary syndrome and is presenting in less than 120 minutes. This guideline, I think this is one of the little changes as compared to the previous one. It recommends that you should still go ahead and do a PCI for the patient. Okay. I'm trying to pick out what was not in the previous guidelines, but largely most of them are actually almost similar. There are no changes. So one of the class 3 recommendations here is routine PCI of an occluded ischemia-related artery is not recommended in STEMI patients presenting more than 48 hours after the symptom onset and without persistent symptoms. Okay, so 48 hours after a patient comes in, and after the initial presentation, you think that this patient might have had, the ictus might have occurred like 48 hours ago. This guideline is saying that routine PCI is not recommended as a class 3A recommendation. So we can take our time and look at those other subsequent recommendations. Let's take a look at this. Okay, fine. I think Dr. Itubi has much easier here. He has spoken extensively about this. This is with respect to anticoagulation of the patient. So in STEMI, in patients who had PPCI, you have the option and the anticoagulation, you can use unfractionated heparin, enoxaparin, bivalirudin, but fondaparinux is contraindicated. It has a class 3 recommendation. Then, but if it is an N-STEMI, the patient has, and the angiography is going to be in less than 24 hours, unfractionated heparin is recommended. If angiography is also less than 24 hours, you can also do, you might consider enoxaparin, but fondaparinux is at this point here, you can look at, you can see it here that PCI in STEMI patients, fondaparinux is contraindicated. The way you're going to do an angiography and might actually take even more than 24 is after 24 hours, fondaparinux has a class 1 recommendation. So after then, the routine platelets, antiplatelets, the treatment that the patient can take, aspirin can be one of them, as a class 1 recommendation. You can use P2 Y12 inhibitor, but in all instances, N-STEMI ACS, the P2Y12 inhibitor is a contraindication. It's not recommended. Then if you want to consider for invasive angiography, your choice of antiplatelet medication, the gold standard is prasugrel and ticagrelor. So you only fall back to clopidogrel if these two are either not available or they are not tolerated. And after all this, you've done all this, patient that is supposed to be on dual antiplatelet therapy. Ideally, the patient is supposed to be having this for about 12 months. So aspirin and a P12 inhibitor is actually recommended for the first 6 months, particularly in patients who are not having a high bleeding risk. Now, if these patients are having a high bleeding risk, there's a different modification of this antiplatelet therapy that you're going to give them. So this recommendation is for patients who are not on a high bleeding risk. So you give aspirin and a P2Y12 inhibitor at least for the first 6 months. Then after the next 6 months, you can consider maintaining one antiplatelet therapy, and class 1 recommendation for that is aspirin. So the next point I want us to also look at here is procedures for de-escalation. Okay, so this is what I was actually trying to allude to earlier. In patients with high bleeding risk patients, the antiplatelet therapy that you're going to do, the dual antiplatelet therapy can be for 0 to 1 month. You're already beginning to step down, but as compared to those who are not on high bleeding risk, you can go as far as 6 months before you will now start thinking of stepping. So this is just a summary of how we're going to go about de-escalate our antiplatelet medications in this patient. So we can also take a look at these quick diagrams. I find them very useful and quick summaries of most of those lengthy messages they're talking about. So next point I want us to quickly look about is not an unfamiliar term, and I think Dr. Florence told us quite much about it. It's the Minoka variant, myocardial infarction with non-obstructive coronary arteries. Okay, so there's instances where this terminology or this concept is beginning to gain quite significant amount of traction in cardiology. It's increasingly being recognized that there are patients who are likely to have symptoms and signs of myocardial infarction. They can have troponin elevation. They can have everything that a myocardial infarction patient is likely to have. But when you do an angiography, there's going to be no evidence of any obstruction in those vessels. So several other things can cause this to actually happen. So one of the common differential diagnoses when we come across that includes what this picture here is trying to summarize. So there could be coronary artery causes, which include embolism itself or microvascular dysfunction. You could have coronary spasms or coronary thrombosis. There could also have a case of myocardial bridging, a plug rupture or spontaneous coronary artery section. The non-coronary causes include cardiac trauma, cardiomyopathy, toxins, myocarditis, Takotsubo cardiomyopathy, or you can have transplant rejection. And non-cardiac causes also can be a possibility that we are looking at when we're dealing with cases of Minoka. It's important for us to have that at the back of your mind. It's actually said to be more common in women. So the long-term treatment for ACS, here, this diagram is trying to depict what entails in the long-term treatment of ACS. So we should discharge on cardioprotective medications. and start lifestyle management and refer patients for cardiac rehabilitation. Okay, they arrange for outpatient department review to manage comorbidities and discuss patient goals and preferences. Our treatment goal, one is to support a healthy lifestyle, which includes smoking cessation, taking healthy diet, regular exercise. Patients should maintain healthy weight and psychosocial management. Second is to continue optimal pharmacological and cardioprotective treatments. This includes antithrombotic therapy, lipid-lowering therapy, annual influenza vaccination, which will promote drug adherence and persistence, and other treatments as appropriate. Then the third goal is to reach and sustain risk factor treatment targets. One is to reach to sustain systolic blood pressure should be less than 130 millimeter mercury, and diastolic to be less than 80 millimeter mercury if the patient tolerates that. Then LDL cholesterol should be less than 1.4 millimoles per liter. I think it was emphasized very strongly about intensification of this LDL cholesterol. I think lower down we will see that it's even recommended that we should add ezetimibe in addition to our statins, which has been found to have a much more faster slope in achieving lipid control. And finally, HbA1c should be less than 7% in this patient. So this, I think this is talking about the recommendations for lipid lowering therapy in acute coronary syndrome. We can also take a look at this. This is where I was talking about combination therapy with statin and maybe it could be considered in the patient depending on what their LDL cholesterol is and how fast we want to achieve that control. But most importantly is that we should know that maintaining, it is not only antiplatelet therapy, dual antiplatelet therapy that's indicated here. The lipid control is also very, very important. So basically this is the important summary about the 107-page document. There's a summary here in table 4 of the new recommendations that was incorporated in this guideline. I think it can also give us a very quick summary of what this guideline is saying, particularly in this period of time where we are short of time and there's no subsidy. So it's already 7:22. I think perhaps this might have reinforced the initial presentation of the 10 Commandments Dr. Etubi has taken us through. Thank you very much.
Wow, thank you so much. Thank you so much, Chief Sawa, for taking up this Herculean task. Thank you. This was an excellent presentation. Thank you, sir. Please, the platform is open for maybe 1 or 2 comments so that we can quickly go to the second guideline too. Please comment, contribution, says a mass. Thank you. Thank you, Chief Sawa. Okay.
Thank you, Chief Sir.
Please,
I want to ask something. Sorry, I want to ask about okay. Please, I want to ask about antithrombotics or antiplatelet and anticoagulant in patients with AF. I know there was something that Prof was explaining that if patient has AF and if they have AF and they have ACS, that then you now look at their bleeding rates, then you now decide whether you're giving them anticoagulants for 1 month, then you continue with dual antiplatelet or something. I was hoping that you're going to talk about it.
Okay.
Thank you.
There are several other scenarios, which I think this document tried to take us through. Let me see. I think somewhere down in the document, they mentioned these instances, and it even includes situations that are in pregnancy, but I can't really bring
You have
it out.
passed it, Dr. Sawa.
Sorry, okay, it's here.
You have passed atrial fibrillation. Yes.
Okay, can you see? Is this the place, right? Sorry, I don't know if anybody has offhand that information. I really don't have it. And I know it's contained in this document, but while I'm searching through it, if anybody has.
You're going back up. It's down, sir.
Okay.
Atrial
Dr. Sawa,
fibrillation, where we have other comorbidities.
You even highlighted it, so I don't know why you went away again.
Oh, okay.
Exactly.
I was asking if that was the, and
yes,
there was no rest. So that was why.
ACS and atrial fibrillation.
No, we thought that you were going to read it out.
Okay, it's here. This one, right? Recommendations for acute coronary syndrome complications. One in AF, they said intravenous beta blockers are recommended when rate control is needed in the absence of acute heart failure or hypotension. Class 1C recommendation. All of them are class 1C actually. Then intravenous amiodarone is recommended when rate control is needed in the presence of acute heart failure and no hypotension. Immediate electrical cardioversion is recommended in patients with ACS and hemodynamic instability and when adequate rate control cannot be achieved promptly with pharmacological agents. Then lastly, intravenous amiodarone is recommended to facilitate electrical cardioversion and would decrease risks of early recurrence of AF after electrical cardioversion if unstable patients with recent onset AF. This did not make mention of
that's as a complication. No, still go down, sir. There's one has a comorbidity. The one you read is as complication. There's one as comorbidity. You have passed it again. You have passed it, sir.
I'm going back.
You see that there is comorbidity on the left. Please, let's trace it to on the right, rather. Sorry. So it's continuing down there. These comorbidities, there should be atrial fibrillation. So they didn't specify. I think it's in ESC then. It should be around here actually. Beta blocker.
All right, probably maybe, I don't know, Dr. Alabi, do you have the full gist about this in order not to take too much of our time? Maybe we can look at it and talk about it tomorrow.
Professor, I don't really have the full gist, but I remembered him saying that I think if patient is having AF and they're having ACS, from the pre-treatment stage, you start them on parenteral anticoagulants, and I think you give them for, is it 1 week after the PCI, then you now give them, you now check their bleeding rates. Please, I'm not too sure. Let me don't confuse you guys. But I know there's
Yeah,
something
maybe
about 1 month. There's something about stopping something at 1 month.
Stop
Then you continue the remaining.
antiplatelets. You stop one of the
Which of them?
antiplatelets.
Platelets.
Yes, but you will still have to continue anticoagulation after calculating the as-bled score. So if you calculate
Okay.
the as-bled score and then you weigh the risk versus the risk of bleeding, but you will still anticoagulate and add 1 antiplatelet to it instead of 2 antiplatelets.
Please come again, Dr. Urimaladi. Dr. Sawa, this looks like what you're saying. What was she saying? Dr. Urimaladi, please come again.
Yes. When we have patients that has atrial fibrillation as a comorbidity, so we'll stop anticoagulation prior to surgery. Then after surgery, we'll give them dual antiplatelets with the anticoagulant for 3 months. So after 3 months, we'll weigh their risk, calculate their as-bled score. So you weigh their risk based on the heart failure, labor, INR, all those things, renal function, systolic hypertension, and all those. So when we weigh and we see that the risk is low, so if the risk is low and we are between 2, so we stop 1 antiplatelet, but we continue the anticoagulant with 1 antiplatelet instead of dual antiplatelets. And after a year, we'll continue with anticoagulation.
all right. Thank you.
Okay. I think I've seen what I jotted from what Prof said.
Offset, okay.
He said if there's high bleeding risks, give triple therapy for 1 month. That's dual antiplatelet and 1 anticoagulant. So give it for 1 month. Then drop 1 antiplatelet. That's what you said, yes, and continue others. Then if there's AF but no bleeding risks, give triple therapy for 6 months and then drop 1 antiplatelet and continue 1 antiplatelet and 1 anticoagulant. And usually the anticoagulant they give is rivaroxaban, 2.5 milligrams BD. I think this is what I jotted from what Prof said. So if there's high bleeding risks, you give triple therapy for 1 month, drop 1 antiplatelet, continue others. If there's AF but no bleeding risks, give triple therapy for 6 months, then drop 1 antiplatelet, continue others.
Okay.
Hello, Chief Alabi.
Yes, sir.
Please, can you help us drop this? Can you do a snapshot and drop on the platform?
Okay. There's another thing we can do, if not that they stole my phone. I remember after this day, he screenshotted something and put it on the WhatsApp page. But because my phone is missing, actually I had a document about it. Like he screenshotted something, Prof posted it that day. So if someone can help me trace back on the group, I'm sure we're going to see this thing I'm saying. Thank you. Hello? Hello?
We can hear you.
Hello, we can hear you.
I notice everywhere is silent. I'm done talking. Oh. Dr. Adinyeju, over to you, please. Or is it Dr.
We thought you were still talking.
I finished.
Okay, please, just as requested, help us drop that thing on the group chat. It will be highly beneficial. Thank you so much. Well, we still have to go to the next presentation. That's the guideline on heart failure. We have Dr. Ruki and Dr. Rimolade. Dr. Rimolade, are you ready? Dr. Ruki, are you ready? So we have both of them. So I don't know. Dr. Ruki, can Dr. Rimolade start first and see if you just add additional? Okay. Dr. Rimolade, over to you, ma'am. Thank you.
Good evening. Okay. Sorry. Good evening. I'm ready. Either way is okay.
Okay. Thank you. I need to share. Sorry, please, I need to share my screen.
You can share. Once you start sharing, to take off is Zoom.
Okay.
Or just to get it clear, so we're kind of like having a, what do we call it?
You said
Relay. We're kind of like having a relay. When Dr. Rimolade finishes, then we add. Oh, good. I see you even focused on AHA. I focused on
yes.
ESC. So
Okay, I have the two actually. I compared the two.
okay, makes sense.
Like so. Okay, I wouldn't know. Okay, I used to. I thought to represent the latter part. Well, I don't know. Let me do what I have then.
Let's just go ahead. We are all discussing together. Thank you.
So please, can you see my screen on slideshow?
Yes, ma'am, we can see it, ma'am. Thank you.
Okay, thank you. So I'll be running through the paper is actually a lot. We have both ESC as well as AHA guidelines. So they are pretty saying the same thing really. So I will just run through. We have 4 stages of hypertension, of heart failure. We have stage A, which is at risk. Those that are without, they have the risk factors and they are without signs and symptoms. They also don't have structural or functional heart disease. We have the stage B, that's the pre-heart failure. These don't have symptoms yet, however, they have structural heart disease. We have the stage C, which are those with signs and symptoms as well as structural heart disease. Then we have the stage D, those are the advanced heart failure stage, the ones Dr. Ruki talked about yesterday or 2 days ago, with marked heart failure symptoms that interfere daily life. Also, they have recurrent hospitalization despite the fact that they are on guideline-directed medical therapy. And we have all the criteria that she mentioned that will qualify for stage D heart failure. However, in stage C, which are those with symptoms, signs, as well as structural heart disease, they could present de novo. They could they could have had, maybe they're stable with resolution of symptoms. There could be those with, despite medication, they still have persistent heart failure. And there are some that have worsening heart failure that progresses to the stage D. So we should know that the diagnostic algorithm, which is important, just like we've been emphasizing that even in defining heart failure now, we have to include not only the structural and functional heart disease, not only the signs and symptoms, and we'll also include that there must be evidence of biochemical parameters of failure, which is the BMP, NT-proBNP, which we use. So in diagnosis, we know still involves the clinical assessment, history, examination, and laboratory findings. Most specifically mentioned the NT-proBNP, anything greater than 125 is what is in the guideline. Then we'll do additional testing with our echocardiography if necessary to make the diagnosis. And once diagnosis is confirmed, we have to actually classify our patients to know where they belong. And we know that now heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction, as you can see. And each category could have heart failure with improved ejection fraction when maybe initially at diagnosis and they had ejection fraction less than 40%, for instance, and with serial assessment, they've improved more than 10% to have heart failure with improved ejection fraction. So the same thing goes also for mildly reduced ejection fraction, can have improved ejection fraction when they improve from less than 50 to above 50. However, for those that improve from less than 50 to above 50, there is still limited evidence as to if medications are to be considered, if patients are to be managed as heart failure with preserved ejection fraction, or still remain, their management to still remain as heart failure with mildly reduced ejection fraction. As we know that those in the class of heart failure with preserved ejection fraction don't have a specific guideline treatments. So these that was HA guideline, and this is the ESC guideline, and it's still the same the same thing they are saying. Really, there are no difference. They have the risk factors, the symptoms, abnormal ECG, then we do the biomarkers. If NT-proBNP greater than 125, which is strongly suggestive, then we do our echo. We have abnormal findings. We classify our patients into reduced, mildly reduced, or preserved. And if there are no ECG, echocardiography abnormalities, that means heart failure might be unlikely in those group of patients, and we have to consider other diagnoses, as we know that heart failure, NT-proBNP could be positive in some other cardiac other abnormalities. I will skip this, please. Then the causes of heart failure, we have different causes. It could be ischemic, non-ischemic, and we have risk factors too, which are stated above. I think I will just run because of our time. And just also, and according to ESC, it's similar to what we have for AHA, hypertension, all those risk factors, the cardiomyopathies, and every other thing as written here. So, like I said earlier, that we might have to consider other diagnoses if NT-proBNP and negative. I'll still get to that. Sorry, there's something obstructing my view. But you can see my screen, that's fine. These are the signs and symptoms. We have the typical symptoms and the typical signs according to the guideline, and I'm sure we are all familiar with this, but it's just good to know that endopnea has entered the guideline as a less typical sign or symptom, of heart failure. So now I move on to the initial evaluation. For evaluation, history, physical examination, as stated there, class one recommendation, we have to evaluate for presence of advanced heart failure complication, even from the point of diagnosis. We have to assess for signs and symptoms with evidence of congestion, which also is part of the guideline definition now. for heart failure, there must be evidence of congestion. So we must assess for that. And then also, as one indication, the investigations that we are to do, full blood count, uric acid is also part of class 1 recommendation of drug. And another thing that I think we don't normally put into cognizance is this TSH. So it's actually part of the class 1 recommendation. Then we do 12-lead ECG, as well as other things that could be specific to whatever the etiology of the heart failure might be. And recommendation, I would just gloss through this based on what the patient presents with. A patient that has dyspnea, for example, it's a class 1 indication that you must do a BMP. Just like most of the points of care lab or points of care investigation device that we have now will run both D-dimer, NT-proBNP together with troponins, highly sensitive troponins together, because according to the guideline, all patients that present with dyspnea should have these investigations done. And if patients actually present acutely with hospitalization, which is also a class 1 indication to have NT-proBNP done. So in other words, most of our patients either presenting in acute or chronic should actually have an NT-proBNP done. It's a class 1 recommendation. However, for those who just have like stage A heart failure, who are just at risk, is only a class 2 A recommendation. Not really, it may be done, but it's not mandatory. The same thing goes for ESC guideline. Have the like I said, the other causes for elevated natriuretic enzymes are stated. I think we once treated this in Prof's MCQ. Advanced age, the non-cardiac causes, advanced age, subarachnoid hemorrhage, renal, COPD, bones, infections, sepsis. We answered this question then, so we just take note of that. And then also other investigations that should be done. Class 1 recommendation is the chest X-ray. Transthoracic echo is also a class 1 recommendation in newly diagnosed patients with failure. And other investigations, including the cardiac CTs, MRI, as well as the SPECT and the PET, are class 1 recommendation in patients in whom echocardiography is inadequate make diagnosis of either the diagnosis of heart failure or getting the etiology. So it's a class 1 indication to do a cardiac MRI, the cardiac CT in the patient. And for patients that we feel or want to evaluate for ischemic heart disease or ischemia, depending on what we see, is a class 2 A recommendation that we can do coronary angiography. However, if patient's clinical status remains unchanged and patient just has like straightforward heart failure picked on echocardiography, NT-proBNP, it's actually elevated, and we are not suspecting ischemic disease in the patient. Invasive investigations are not recommended. They are class 3 indication. So also invasive hemodynamic evaluation is just in selected patients that we should do. In most instances is of no benefit if there are no strong indications to suspect ischemic or heart disease in the patient, or any to suspect any form of maybe infiltration, maybe in case of amyloidosis, that we might not have to do all the invasive investigations, unlike if you can get all our diagnosis from echocardiography. Same go for endomyocardial biopsy is only done for selected patients. And if we still remember, we've taken endomyocardial biopsies and we have 2 class 1 indications, that's rapidly progressing heart failure symptoms occurring within 2 weeks and would be a class 1 indication for endomyocardial valves. In the absence of other infiltrative lung disease, or maybe you are thinking of chemotherapy-induced cardiomyopathy, we might not actually have to do endomyocardial valves in these patients. So the other things we will have to do depending on the stage a patient is presenting. Most of our patients, if they are stable enough, would class 1 recommendation would be an exercise and functional capacity testing in this patient, and this might be done most times to prognosticate patients and also to be able to know the functional capacity of this patient by doing functional capacity testing in them. It can be done either on the treadmill or using a 6-minute walk in this patient. Then, for patients who are at risk of heart failure, those that present with stage A, it's recommended that we prescribe lifestyle modification for them, right from diagnosis, for those who are at risk. And for patients who already have hypertension, you actually optimize BP control. For those who have type 2 diabetes, you consider adding an SGLT2 inhibitors to their medication just for primary prevention. For those who have other risk, who have had cardiovascular other risk, or who have had any cardiovascular disease, you optimize management of cardiovascular diseases. These look out for their cholesterol, reduction of weight, and then if they have peripheral arterial disease, we also manage those. Those who have first-degree relatives, we have to also who have first-degree relative with genetic or inherited cardiomyopathies. We have to do genetic screening for them so that to be able to pick early, despite the fact that they don't have the structural abnormalities or they don't even have symptoms yet. But we have to keep screening since there is a positive family history in them. And for those who are stage B and heart failure, that's pre-heart failure, those that have structural heart disease but don't have symptoms, if their ejection fraction is less than 40, we have to start them on medication for reverse remodeling with the class 1 indication. For patients who have a recent MI and they have a left ventricular ejection fraction less than 40, you also have to give them AC inhibitors or ARMs if AC inhibitors are not tolerated in them. And for those who not symptomatic but have left ventricular ejection fraction less than 30, and they have greater than 1 year survivor rates, 40 days and post-MI, we actually have to is a class 1 indication for an ICD, despite the fact that they are asymptomatic for heart failure. For we have to prescribe ICD for them. For those who have non-ischemic cardiomyopathy, we may do genetic screening for them, despite the class 2 recommendation. That would be, we should do a genetic screening for them. It's a class 2A recommendation, despite the fact that they lack a family history in that instance. Then this is like treatment algorithm for heart failure with reduced ejection fraction. Now focusing on stage C and D. The first step is when we see patients with established diagnosis of heart failure, and we initiate guideline directed medical therapy. That's the first step. If their ejection fraction is less than 40, we start patients on pillars for heart failure management, beta blocker, the HANI, MRA, the SGLT2, and diuretics as needed. We should note that the first 4 are class 1 inpatient, and they are the pillars of heart failure management. Diuretics is also class 1, not regarded as part of the pillars, just for
symptomatic relief. Then if after doing that, then in all down the line, if after doing that, we, as we follow up patients, we will titrate medication based on laboratory assessment of the patient as well as tolerability with the blood pressure. We, as they come to clinic, we assess them. For those whose injection fraction does not improve despite being on guideline and directed medical and therapy, they still have persistent LV, severe LV dysfunction. Those are those that will step up to step 3. But for those whose injection fraction improve from less than 40 to from less than 40 to greater than 40, those ones will continue their guideline medical therapy down the line with lifestyle modification. For those who don't improve, still having NYHA class 3 or 4, and those who still have their ejection fraction less than 35, or those who have in sinus reading and the KRS greater than 150. So for those who, despite medication, they are still in class 3 or class 4, they can, in addition to the guideline medical therapy, which we talked about in step 1, we had adrenaline and nitrates to them. That's the class 1 indication, provided that their blood pressure can tolerate it. If the left ventricular ejection fraction is less than 35, and they have greater than 1 year survival and still symptomatic despite guideline directed medical therapy, they would prescribe high CD for them. That's class 1 indication. However, if they are in sinus rhythm and the QRS complex is greater than 150 and with LBB pattern, that's the class 1 indication for a CRT in this patient. If after looking at all this clinical scenario and we've added all these we are adding to continued guideline medical therapy, if still the heart failure does not, if the symptoms improve after this, then that means we continue with our guideline medical therapy, rehabilitation, as well as lifestyle modification. However, if symptoms does not improve and the patient still remains in stage D heart failure, that means the heart failure is refractory. So if the heart failure is refractory, what next can we do? That moves us to step 6. And in step 6, the things we can do, I think Dr. He told us about this yesterday. We that use a mechanical support, or we do a cardiac transplant, or we place patients for palliative care, which are all class 1 indication in that case. That's for heart failure with reduced ejection fraction. So additional medical therapies after using or after optimizing guideline-directed medical therapies will be depending on the clinical scenario. If we have heart rates after optimizing beta blocker to the maximum tolerable dose, and we still have the heart rate above 70, then we add ivabradine. We may add ivabradine. That's the class 2A indication. If we should add, that's the class 2A indication. If, however, despite being on guideline directed, we still have elevated NT-proBNP, ejection fraction still less than 45, and we still have patient is still on, is not really, is still on IV diuretics, and patient is still not doing well, then we may add variguat and in the dose that is stated, and the cardiac dose, optimal dose here is 10. Optimal dose for ivabradine is 7.5, and the initiating dose here is 5. Initiating dose here is 2.5. And also, there are some patients which digoxin might be considered. In cases where patients still symptomatic despite guideline-directed medical therapy, or in patients where BP cannot tolerate high dose, it's not allowing us to give the maximum doses that will be beneficial to the patient because of hypertension or low BP, then we may consider adding digoxin. The guideline also says we can consider adding we call them, they are fatty acids, polyunsaturated fatty acids for patients who are in NYHA class 3 to 4 with heart failure, but that should not be in isolation. It should be with guideline-directed medical therapy. Also, for those who have hyperkalemia and maybe because of the diuretics or because of renal, let's say diuretics, ARBs or AC inhibitors, and the mineralocorticoid receptor antagonists, we might add potassium binders for them as class 2B indication. So, that's for AHA and this for ESC, and it's practically saying the same thing. The 4 pillars are class 1 indication together with loop diuretics when needed, class 1. And those that will benefit from ICD, just like we have for AHA2, LV, left ventricular ejection fraction less than 35. When the KRS is less than 130, patients will benefit from ICD, and it's to be a class 1 indication if patient has concurrent ischemic heart disease, and a class 2A indication in the presence of a non-ischemic heart disease. While for those who are in sinus rhythm, ejection fraction less than 35 and a QRS greater than 130 will benefit from a CRT, just like we have for AHA guideline. And the more the QRS length or widening, the more the patient will benefit from the CRT. So it's class 1 if it's greater than 150, and class 2A if the QRS is greater than, is between 130 to 149, which is actually similar to the AHA guideline. And also, if the left ventricular ejection fraction is greater than 35 and patients and therapy is not indicated, that means the patient does not have ejection fraction less than 35 and also does not have the QRS complex widening, we may consider ICD as a class 2B recommendation. So, and just this also from ESC guideline, just like we had for AHA guideline, 4 pillars, then we had directives as needed, then specifically for those that require CRT or high CD, as the case may be, which I just said, and for instances where we have to add digoxin, like in atrial fibrillation, although AHA was silent about that in that algorithm, but we talked about it later. But at least we know that digoxin can also be added in atrial fibrillation, and also when patients cannot tolerate, they are not able to titrate our medication up, and also give digoxin. Anticoagulation for those who have atrial fibrillation, coronary artery bypass grafting for those who have multivessel disease, or for those who have who cannot benefit from PCI and they have acute coronary syndrome. Iron deficiency, those who have that will also prescribe ferric carboxymaltose, also in the guideline. So other things that we can do depending on which other things patient presents with are stated. Patient who will require mitral valve repair, those who have sinus rhythm and their rate is still above 70 despite up titrating of beta blocker, we had ivabradine. And for aortic stenosis, we talked about this, those that will need surgical or catheter valve replacements depending on the stage of the stenosis, which they belong to. And after all this, we still talk about it. There's room. I've said that we continue looking out for lifestyle modification and also look out for exercise and rehabilitation. We talked about it in the AHA2. So it's also in the ESC guideline. So we've talked about this, it 2 years today, and I've mentioned it. It's just for those who benefit from CRT, and we've said those who have left ventricular ejection and fraction less than 35, and the class 1, those who falls into class B, 2A, and those who fall into class 2B. So when we have those who have non-LBB, non-LBB QRS widening, it's a class 2A recommendation. And for those who have LBB less than 150, would be class 2A. Those who have non-LBB would also be a class 2B, so may be recommended. However, for those who are in NYHA class 1, but who have their ejection fraction less than 35, may also benefit as a class 2B indication. But since they're in class 1, most times we tend to leave them, but they may also benefit in case you see in MCQ. For those who have left ventricular ejection fraction greater than 35, but who have high-grade complete heart block, we should consider them for pacemaker. And I'm sorry, for CRT, since we are going to do a pacemaker for them anyway, so it will be a CRT. So on CRP rather. So in some special circumstances too, for those who have maybe AF and they want to have a right ventricular pacing is anticipated in them, there's no point pacing the right ventricle since patient is in AF. So we just synchronize this patient, or those who are not in sinus breathing and require a right ventricular pacing, like we always say, should just synchronize. So these are additional treatments or device therapies, so to speak, for some specific patients. For those who have select patients with heart failure with reduced ejection fraction less than 35 and are suitable for have suitable coronary anatomy, revascularize, and those who have severe secondary MR, we optimize medical therapy and also do class 1 indication for intervention in them. And for those who have NYHA class 2 to NYHA class 4, have suitable valvular anatomy with secondary mitral regurgitation, we should actually do a transcatheter mitral valve repair for them. And for those who have elevated MP levels, despite the guideline-directed medical therapy still in stage 3 with history of recurrent heart failure or hospitalization, would also benefit from wireless pulmonary artery pressure by implantable dynamic monitoring, just a class 2. So we may describe that for them. So I think we've gone through this before, as a mitral regurgitation, done this when to do intervention in this patient. We've gone through this. If the ejection fraction is greater than 50, and patient is in failure, it means patient is symptomatic anyway. So that's like class D. So if patient is stable and suitable for surgery, if there's persistent symptoms despite guideline directed medical therapy, which is the first to do in setting of the secondary mitral regurgitation. By this, we mean that the heart failure is actually the cause of the mitral regurgitation, maybe from annular dilatation, which advocated that we do a guideline directed medical therapy for them. And it's also important to note that for patients who have secondary mitral regurgitation and they qualify for cardiac resynchronization therapy, most times after the resynchronization therapy and we assess, they have improvement in mitral regurgitation. But if not, we could go ahead to do transcatheter if they fulfill this criteria. Say ejection fraction continues to dip despite guideline directed medical therapy, and also device therapy as the case may be, might go ahead to do replacement or repair of the valve. However, for those who does not meet the criteria, ejection fraction still greater than 50, or are considered for a coronary artery bypass graft, it will be reasonable to do a mitral valve surgery or repair for those in that category. So this also treatment for of heart failure with mildly reduced ejection fraction. So heart failure with mildly reduced ejection fraction, what we do is diuretics as needed, and we had other evidence-based maybe pillars like the honey, the ARBs have been useful, the LGLC, but they are all class 2 indication for these patients. Although for those who have patients with heart failure with improved ejection fraction after a guideline-directed medical therapy, it's advocated that they should be continued on their guideline-directed medical therapy as a class 1 indication in addition with diuretics as needed. So for heart failure with preserved ejection fraction, as we know, there's really no clear study to show benefits as regards some medications, especially the honey, the MRAs, and the ARBs. But however, we can use them as class 2B indication, while our diuretics are class 1 class 1 indication, and the SGLT2 are class 2A indication for those patients. So for patients with amyloidosis, I think we've gone through this before. We know how we make diagnosis, but it's important that we have to separate patients that have AL amyloidosis from those that have ATTR, either the wild form or the genetic variant or the variant form, because their management are actually different. For those who have AL amyloidosis, they will require being referred to hematologists, and chemotherapy will actually be started for them. While those that have ATTR form are those that will actually benefit from tafamidis, and they are supposed to be anticoagulated if they have atrial fibrillation, irrespective of their chargeback score. That's the class 2A recommendation. And for those who have the variant type, which will be referred for genetic counseling, and as well as the family screening, and also benefit from the silencer therapy if they have neuropathy. So advanced, okay, I think Dr. Ruki has taken this yesterday, and Dr. Ayodeji also mentioned this. That's the criteria for diagnosis of the advanced heart failure. Talked about this exclusive yesterday. I need help was the code that Dr. Ayodeji gave us, and that's what is showing here. End organ damage. Patient has to be on intravenous inotropes, ejection fraction percent less than 65. The current to admission. Patient receiving several shots, especially they are on ICDs, they have ICD home, or they have to come to the hospital for third shock, and persistently their BP are low, and they still have an aspaka despite unescalated doses of diuretics. So these are the caliber of patients that qualified for advanced heart failure. And Dr. He has taken us through those inotropic supports. So I won't have to go and mechanical supports on that. Cardiac transplantation, we talked about it. So now running to those that present with acute decompensation of chronic heart failure. Acute decompensation of chronic heart failure, managing them. Class 1 indication is for us to address precipitants, evaluate for severity of congestion, and also for adequacy of perfusion. And the goal of management will be to optimize the volume status of the patient, address reversible factors that brought the patient to the hospital, and also we continue to, or we initiate if patients are not in compliance, or if patients are not in place on guideline directed medical therapy, we do that, or we continue. And the common factors that precipitate acute decompensation are stated here. So the same for ESC, they said the same thing. Patients who come in acute decompensation is just similar to what we have for AHA2. We run all our tests. We do the algorithm for diagnosis is what is here. So we check the NT-proBNP. If NT-proBNP is less than 100, then acute heart failure will be ruled out in that cohort of patients. However, if the NT-proBNP is greater than 100, and then we confirm that patient is in acute decompensation, and we do a comprehensive echo while we look for things, maybe structural abnormality that would have brought the patient. And during hospitalization, these are the things that we do. Class 1 recommendation, I've mentioned them, diuresis, and guideline-directed medical therapy, VT prophylactic in patients on the ward, and also when they come acutely, we know we all do this. We consider disconnecting the drugs that will worsen their condition, like the beta blockers, those that have low cardiac output, or the honey in those that have acute kidney injury, or in those that might have angioedema. So when we decongest, actually, if we decongest these patients, we do our electrolyte and creatinine, we continue to give, or we initiate parenteral diuretics in this case, and we titrate based on patient's blood pressure, and also based on the presentation of the patient. Like we said earlier, class 2B indication, glycerin or nitroprusside will be added to diuretics in this patient to help with preload as well as afterload, but it's a class 2B indication. That's if the blood pressure can be tolerated. Then for patients that present in cardiogenic shock as a component of their acute decompensation, the criteria, we've gone through this severally. Systolic blood pressure less than 90, or we have the blood pressure requiring vasopressor. And when they require vasopressor, the cardiac index here will be when it's less than 2.2, as against without vasopressor that we use 1.8. We talked about it before. These are the other criteria. Lactate greater than 2, urine output less than 30, patient will have cold scanning extremities, decreased or altered sensorium. And we also talked about the PCW. Okay, we talked about the cardiac index, and this is 15. I think we all know this about it. And the class 1 indication to commence or to initiate ionotropes in this patient for the management of cardiac shock. So ESC also says the same. When patient comes, it's congested and maybe there's overload. Then if there's hypo perfusion, we still have to give directives, and we also consider inotropes, and we follow the line down. If patient needs renal replacements, we give. If here is saying we should consider vasopressors, class 2B indication is norepinephrine in this case. If symptoms are not relieved on time, and loop directives and other increased directives as patients can tolerate if there's no hypoperfusion, meaning either or not the blood pressure is low or high. The first call, I think we treated an MCQ like this, still loop directives. That's the first thing we do first before we consider inotropes still, and follow for renal replacement or palliative care as the case may be. So for patients with pulmonary edema, I think this was like what I used for the question I discussed yesterday. We give oxygen and ventilatory support, and I said if blood pressure is greater than or equal to 110, we'll be able to use that high dose directives. But if blood pressure is less than 110, and we have signs of hypoperfusion, we'll give low dose of directives, and we also have to give inotropes in that instance. And when we have relief of congestion, we optimize medical therapy for the patient. But if not, we would consider mechanical support devices in these patients. So this talks about management of patients with isolated right ventricular failure. The AHA were quite silent about this, but the ESC says for patients that have an isolated right ventricular, either from ACS with right ventricular involvement or right ventricular involvement from acute pulmonary edema. If we don't have, if we have any of these, to give specific treatment. Specific treatment being that we'll treat the ACS as the case may be, and the pulmonary embolism as the case may be. But if none of this is present, then we would optimize and give status of the patient. Then we would, if there's marked congestion, we give high dose directives as the case may be, and go down the line to give them vasopressor if blood pressure is down. Patients might even also require right ventricular assisted device if symptoms does not resolve. So this also talks about for patients in cardiogenic shock. We've seen this with AHA and this for ESC, and then they are actually saying the same thing. Nothing actually different. It's just to compare the two for us to see. Because of time, I guess I'll just move on. Then transitioning of care following discharge of patients. We follow up patients ideally within 7 days. It's class 2 recommendation following discharge. And when we discharge patients, the class 1 indications to communicate with patients at discharge plan prior to discharge of the patient. And the discharge plan should include early training follow-up, which should come, the initial follow-up will be within 7 days where we assess patients, and also require for multidisciplinary management, the class 1 indication for patients who have comorbidities, and adjusting directives and coordinating safety of laboratory checks from serial and especially electrolytes and HbA1c, uric acid, and the likes if a patient has comorbidities, especially diabetes and CKD as the case may be, and this must be communicated to the patients before discharge as class 1 recommendation. So additional things we had to optimize the guideline-directed medical therapy would be based on what actually the patient is presenting with. Like if the patient has heart failure, we anticoagulate. If a patient has cancer, maybe heart failure with cancer, to be a multidisciplinary management. If patient has the selected patient with suitable coronary anatomy with left ventricular ejection fraction less than 35, surgical revascularization is mandatory class 1 indication. For those with type 2 DM, mentioned the estimate of benefits from SGLT2. Those with hypertension to give them guideline or optimize their blood pressure case may be. And the others, those that require iron supplements would also give as class 2 recommendation. So, okay, I've said that on this previous slide, so I will not have to go through it again, but these are the other adjuncts, those that have sleep disorders, diabetes, hypertension, as well as anemia should be taken care of. So, heart failure with atrial fibrillation, class 1 recommendation, it's patients with chronic heart failure with permanent, persistent, or paroxysmal AF and a CHA2DS score of greater than 2 in men or greater than or equal to 3 for women should receive chronic anticoagulation therapy. And then also patients with chronic heart failure with permanent or persistent paroxysmal AF, DOAC is recommended over warfarin in eligible patients, meaning those who do not have valvular heart disease. So tend to promote NOACs more than the warfarin if we have to have calculated the CHA2DS score of the patient. So maybe I'll just run through this. Vulnerable groups, depending on several population, those with cardiovascular disease risk would require HAVs because of time. Oncology, class 1 indication would be that patients who develop cancer therapy-related and cardiomyopathy should actually have a multidisciplinary approach to treatment, and treatment might be interrupted or discontinued as the case may be, unless patient has like an improved cardiac function after discontinuation. There are some drugs that we can use, beta blocker, especially carvedilol and desoxyzine, which has been licensed in the UK for the management of cancer therapy-related cardiomyopathy. And then heart failure and pregnancy, yeah. So for pregnant women, it's a history of heart failure or cardiomyopathy, including previous history of peripheral cardiomyopathy. Patient-centered counseling regarding conception should be given, and the risk of cardiovascular deterioration during another pregnancy should be communicated to the patient as a class 1 indication. Patient. So meaning that before a patient that has a cardiomyopathy or previous history of PPCM gets pregnant, they should have been counseled on the possible risk. That's a class 1 indication in them. So they said there that the women with heart failure or cardiomyopathy who are pregnant or currently planning for pregnancy, this medication, ACE, ARBs, ANI, MRS, SGLT2, ivabradine, and variciguat should not be administered because of the significant risk of fetal harm. So it's a class 3 indication should not be used in this patient. However, anticoagulation use class 2 indication in pregnancy. I think that's basically all we should, and that's the health-related quality of life measures. I think I'm just gloss through over these at our leisure, should be able to take this so that we don't waste time on it. Thank you so much for your attention.
Wow, thank you so much, Dr. Malari, for that. Thank you. Thank you. Dr. Ruki, I know you have some additional things to just mention before we welcome questions and comments from others. Just let's just note down our contributions. Dr. Ruki, are you still there?
Yes, ma'am.
All right. Thank you.
Okay. Thank you, Dr. Orimolade, for this very extensive review of the guidelines and for comparing the two. I actually had focused more on the ESC, but you have filled in that gap very well. Thank you. So what I'm going to do is really very short. She's done most of the heavy lifting, and I'm just trying to share a document. While I'm doing that, so sorry, I was talking and my mouth was muted. Thank you very much, Dr. Orimolade, for the very extensive review. I had actually focused more on the ESC. So, I mean, given that I get the feeling that most of our girls are ESC, there's a very heavy ESC presence within the Nigerian cardiac community. But of course, there's some ACC, AHA. And so thank you very much for filling in that gap. I hadn't reviewed the ACC-AHA guideline extensively. And I would like to say also that, so while I'm putting up some material that I want us to use for the presentation, why do we use guidelines? It's a bit cumbersome. Every few years, we're like, oh, this was recommended before, but now it's discouraged. And that one had a consider using it, but now it has a strong recommendation. Why do we use guidelines? Now, I think of all these specialties, cardiology is probably one of the most evidence-based, and a number of the earlier systematic reviews and meta-analysis, I believe, were done in cardiology. So for instance, like using, I think, aspirin immediately after an MI, there was some conflicting evidence initially. Some studies showed benefit, others, but it was when a meta-analysis was done, pulling all of these studies that were considered good quality together, that the real benefit was, demonstrated. Okay, so I think the echo should be gone now. I think it's gone now. I hope I didn't misfire that with the aspirin. I read it in some historical reviews also. But so when we have a patient in front of us and we want to treat them, frequently, if you had to take the decision on your own, should I give beta blocker? No, only diuretic is enough. No, only digoxin. Versus if somebody had sat down, a group of experts had sat down and look at all or much of the evidence available in terms of support for this treatment over the other one, or this procedure, or timing this before that, and all of that, as opposed to you having to maybe read individual studies and decide for yourself whether this is something you should adopt or not. So that is why guidelines are there to guide management and peg some standard to which conditions should be managed, but still with some discretion, of course, on the side of the managing physician. So to start with, I put together the recent heart failure definitions. Although they are all similar, but so this is the one that most of us are familiar with. It was one of the definitions that put together most of the components that describe heart failure, and for a long time it was being used. Even the updated versions still have similarities with this, but I just wanted to go through them in the event that, you're asked to do some comparison or whatever. So heart failure, we would frequently define. So again, the definition evolved. When we're in med school or prior to now, would be told that heart failure is inability of the heart to pump blood to meet the body's demand. But then you think, so what of shock? So that has been largely replaced by, we've recognized that it's a syndrome, with typical signs and symptoms that then has certain manifestations or is due to certain mechanisms. So heart failure is a complex clinical syndrome, according to the ESC 2016. So clinical syndrome appears in all of the definitions, usually complex, that results from any structural and or functional impairment of ventricular filling or ejection of blood. Here, trying to capture both the diastolic and systolic, contributions to heart failure, resulting in a reduced cardiac output, which was initially the main focus of heart failure pathophysiology and the main one for heart failure reduced ejection fraction, and or increased ventricular pressures at rest or during stress to kind of incorporate the moderately reduced and the HFpEF altogether. So over time, the role of natriuretic peptides, so B-type natriuretic peptide and its N-terminal precursor, was recognized not just in diagnosis, but also in monitoring, in prognostication, and all of that. So it was bumped up, it was bumped up into the diagnosis. So in 2021, a number of heart failure societies came together. So the Heart Failure Society of America, which I believe is under either the ACCHA, then the Heart Failure Society of ESC, the Japanese Heart Failure Society, and was endorsed by the Canadians, the Indians, the Australians, New Zealanders, and the Chinese. So a universal definition, just like we have universal definition for MI as a clinical syndrome. So we still see clinical syndrome appearing with symptoms and or signs. So we will find that the symptoms, I think this ESC 2016 I shared was incomplete because I know they talk about typical symptoms which may be accompanied by signs. I'll recheck these. I put this together very like in a rush. But we talk about symptoms, presence of symptoms and or signs caused by a structural and or functional, so we have to demonstrate some cardiac abnormality, and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic congestion. So we see congestion being bumped up. And when we talk about acute heart failure, we hear about congestion a lot. And there's a lot of advancement in, diagnosing congestion, including things that may not, I don't think lung ultrasound is yet in the guidelines, but there's a lot trying to find how much its utility in the diagnosis and management of acute heart failure. Okay, and the stages which Dr. Malade has already told us about, HFrEF with reduced ejection fraction, HFrEF, which was previously called with mid-range ejection fraction, but over time it was discovered that it looks really much like HFrEF in terms of the etiologies, in terms of their response to treatment and all of that. So that's why it was renamed to with mildly reduced ejection fraction to kind of emphasize their relationship, let me say, and HFpEF, and then HF with heart failure with improved ejection fraction. So the ESC, the ESC reviews its guidelines, I think, every 5 years. The previous was 2016 and then 2021, which we recognize that it's not a single pathological diagnosis, but it's a clinical syndrome. So everybody agrees it's a clinical syndrome, which has cardinal symptoms. So we were shown earlier the list of, was it specific and less specific symptoms that may be accompanied by signs. So the symptoms tend to be more consistent than the signs, which are very familiar to us and is due to structural and or functional abnormality of the heart. So again, we see emphasis on demonstrating some abnormality in the heart because there are conditions. Now think of anemia. Decompensated anemia will give symptoms that are very similar to heart failure, but the heart in and of itself is normal in terms of its structure and function. If it's just decompensated anemia, while if it's anemia precipitating heart failure, then we would find some structural and or functional abnormality of the heart that results in elevated intracardiac pressures and or inadequate cardiac output at rest or during exercise. So the ESC tries to emphasize this, whether at rest or during exercise, because some of the symptoms and findings are exertional. While the ESC which we just finished, the ACC AHA, which we just finished going through in 2022, came up with a very simplified form. So again, complex clinical syndrome. We have symptoms and signs, and it results from structural or functional impairment of ventricular filling or ejection of blood. So still kind of maintaining that there's some systolic and diastolic component. But in any case, we have to demonstrate structural or functional impairment of blood. There's a impairment of cardiac function. This is to emphasize the difference between, I'm sure we have had consults to come and review patient with heart failure and they never had a heart failure. It was something else causing their dyspnea, causing their leg swelling, and all of that. So I just wanted to emphasize the definition. So there is clinical syndrome. You can call it complex if you want. There's accompanying symptoms and signs. There's accompanying structural and functional abnormality of blood. Then you can add of ventricular filling or ejection of blood. You can add urine rest or exercise, or you can add with accompanying signs of congestion or elevated natriuretic peptides. Am I clear so far? Can I go on? I think we've been on this for a couple of hours, so just checking to see that people are following. Hello.
Hello, we are here. No, we can't see
Okay.
your slide.
Yeah. Yes, I'm changing. So
Okay.
after these two guidelines were published, there were a couple of ongoing trials that now were concluded and their results became available. The ESC felt the need to revise some of the recommendations that had been made in the 2021 guideline, and they released a focused update, they called it, a focused update of the 2021 guideline last year. So the ESC has a focus update, a 2023 focus update of the 2021 guidelines. Now, I will just pick on the main important points. The main important points of why these guidelines they came up with this focus update was because of the treatment of HEF-MREF and HEF-PEF. Prior to these guidelines, I think the two main trials of sodium glucose co-transporter inhibitors in heart failure or preserved ejection fraction, I think were not fully concluded, or one was concluded, but then the other was not. I think Deliver was concluded first. Was it Emperor Preserved? I forgot. I mean, I'm not too certain at the moment. But the two major heart failure or preserved ejection fraction guidelines, which are trials on SGLT2, which are for dapagliflozin, we have Deliver trial, and for empagliflozin, we have Emperor Preserved trial, came out, and the two of them, their findings were mainly consistent. There was improvement in they agreed with each other. So now we had more than one RCT giving us consistent findings, and this prompted a review to bump up, like give the SGLT2 in HEF-MREF and HEF-PEF a higher recommendation. Okay, so they showed improvement in hospitalization, improvement in mortality, in addition to improvement in, I think, symptoms and quality of life. Let me not misquote, but clear improvement in hospitalization and cardiovascular death. And I always say cardiology is obsessed with outcomes. So anything that can improve survival or hospitalization gets a green light, at least if it can safely do so. So we have a revised recommendation for use of SGLT2 inhibitors in heart failure with mildly reduced ejection fraction. In the presentation we just finished with Dr. Orimolade, it was a 2A indication in the ACC-AHA 2022 guideline that we just saw. So whether they will also bring out a focus update or will wait till it's time for another, it's routine schedule time for another guideline to do that, I don't know. But here the ESC felt the need to do that. So we have a class 1 recommendation for use of SGLT2 inhibitors at this point in time, dapagliflozin and empagliflozin. I know there are trials going on for sotagliflozin, but I don't know what their status is, whether they've been finished or not, or what the findings are. and is recommended for patients with HEF-MREF to reduce risk of hospitalization or cardiovascular death. The level of evidence is the highest. There are multiple randomized control trials which have showed consistent findings. Same here for HFpEF. Okay, HFpEF, same. Use SGLT2 inhibitor. So it's the first drug that has consistently shown benefit in terms of mortality and hospitalization for HFpEF, as opposed to all of the others that have a 2A or 2B, because there wasn't clear improvement in hospital, especially in mortality. Some had improvement in hospitalization. But at this point, let me talk about ARNI, that's angiotensin neprilysin inhibitor, sacubitril valsartan in HFpEF. The trial for that was the Paragon HF trial. And a lot of people have like proposed probably reanalyzing it, like post hoc analysis, subgroup, and all of that, because the p-value for improvement in, I think, mortality in one of the outcomes, and in the outcome, narrowly missed statistical significance. I don't recall what the exact value was. Was it 0.5 something or 0.6 or 0? It narrowly missed statistical significance. And anybody in the statistics and research space will know that there's like ongoing debate about the utility of the p-value, because basing decisions solely on the p-value might have limitations, because sometimes there can be clinical significance without statistical significance. And what is the difference between 0.49 and 0.51? One is less than 0.05%, 0.05, sorry. So 0.049 and 0.051. One is less than 0.05, the other is greater than. And then we reject one null hypothesis and we accept the other. But I think that debate is beyond this class. But just to show that that's part of the reasons why ARNI are class 2A, you know. And okay, so this is for HEF-MREF. So now we have class 1 recommendation for diuretics and EMPA or dapagliflozin, while the others remain class 2 recommendations. For HEF-PEF, we can give diuretics. We should. It's recommended class 1 for diuretics, DAPA and empagliflozin, then treat the comorbidities, because comorbidities have been shown to really influence the development, the burden of symptoms, and improvement in heart failure of preserved ejection fraction, including obesity, blood pressure control, renal impairment, and all of that. Now, another thing that was emphasized was, okay, even in the previous guidelines, I'm sure Dr. Maladi's, focused on the more pertinent issues because of time, is multidisciplinary management with heart failure management teams or centers. I say again, a lot of these guidelines come with countries that have like structured care. So if you have a hospital, it's attached to a tertiary or referral center where it can send patients that have met certain criteria and all of that. So the need for that, like having centers where there's expertise and excellence in heart failure care and having multidisciplinary teams for heart failure. The other thing, before I move on, is, so we've seen that there are 4 pillar drugs for heart failure with reduced ejection fraction. We can, of course, with diuretics being another therapy, but not listed as the 4 pillars. So I'll say loop diuretics, beta blocker, that's 1 class, AC inhibitor, ARB, ARNI, that's 2nd class, MRA, mineralocorticoid receptor antagonist, that's the 3rd class, and the 4th, SGLT2 inhibitors. Now, there's a debate around, should we introduce them sequentially? Should we do them all at once and all of that? Overall, there is evidence to suggest, and I think this, let me see if this guideline showed it. Yes, management strategies. 2 of the large trials that were published around how should we introduce these medications. In summary, they have shown that introducing them quickly in the absence of contraindications, of course, and while instituting like monitoring pulse, heart rate, blood pressure, electrolytes, especially potassium, renal impairment, improvement of symptoms, presence of congestion. If we can monitor these closely, and if the patient doesn't have contraindications to use of the drugs, then it is advised to introduce them quickly, preferably if patient is on admission before they are discharged. The strong HF trial mentioned here tested sequential or like introduction of beta blocker, RAS blockade, that's ACE inhibitor, ARB or ARNI, and MRA. At the time, I don't know why, but SGLT2, they didn't include SGLT2 in them. And, you know, they looked at things like, okay, will patient become hypotensive with, but generally they have better outcomes if we try to give the drugs. So try to introduce them, I think, before discharge, 2 to 3 days before discharge, then set up a follow-up within 7 to 14 days after discharge, just to look for side effects, worsening condition, electrolyte imbalances, like we said, hypotension, bradycardia or otherwise, and all of that. And to try to have the patient on all of these drugs within 6 weeks of their admission. So by 6 weeks, they should be on them, and to titrate the dose as needed to the maximum tolerated doses for the patient. So just to put that, so in case we have that question of how should we introduce them, try to introduce them as quickly as possible while trying to mitigate and look for side effects, and of course in the absence of contraindication. So if a person is obviously bradycardic, of course we wouldn't go ahead, so pulse rate of 30, and bombard them with beta blockers or something like that. Or if they're hypotensive, we wouldn't give, you know, I mean, you get what I'm saying. So it says here there's a class 1 recommendation for an intensive strategy of initiation and rapid up titration of evidence-based treatment before discharge. So in patients who have been admitted with acute heart failure, and during frequent and careful follow-up visits in the first 6 weeks following a heart failure hospitalization is recommended to reduce the risk of rehospitalization or death. Okay. Another update is the use of SGLT2 in patients with CKD and diabetes. A number of studies, DAPA, CKD, EMPA kidney, and all of that. And we see that the most benefit in terms of CKD and heart failure is in patients who have comorbidity of both type 2 DM and CKD. Of course, we know we use SGLT2 inhibitors in the absence of type 2 DM, we know that. But the most benefit with class 1 recommendation after review of a number of these trials is that in patients that have type 2 DM and CKD, even if they haven't yet developed heart failure, we should give them SGLT2 inhibitors to reduce the risk of heart failure hospitalization or cardiovascular death. So this is saying even before they have like full-blown, I think, heart failure. Let me just go back to the, yes, to some of, it says introduction. Yes, so there were randomized control trials that stopped early for efficacy, and a meta-analysis was recently published to show that they had both diabetic and non-diabetic patients, but the diabetic patients with CKD had the most improvement. Okay, so for instance here, risk of secondary outcome of heart failure hospitalization of death was reduced by dapagliflozin closing. I was trying to confirm the part of whether if they had, okay. So they, yes, so overall only 468 of these 4,000 patients had a history of heart failure. So yes, I just wanted to make sure I wasn't misfiring to say that even if they hadn't yet had heart failure, we should give them SGLT2. Okay. Then yes, this is another important one. We did see in the investigations to be done, as shown by Dr. Maladi, that we should do iron studies. Okay. It is recommended to do iron studies in patients with heart failure. I don't know if we routinely do. I doubt. at least we do full blood count and follow it up with iron studies to rule out iron deficiency, because there's evidence to show that giving iron replacement, I think there's some of this even in the past, but the evidence is strongest now that there's clear benefit for giving iron replacement, intravenous iron replacement in patients with heart failure and iron deficiency. And if we may recall from our basic hematology, there are patients who have iron deficiency, so all of the iron stores are exhausted, but they haven't yet started to show like features of anemia. So one of the main ones was this Iron Man trial. At least it's easy to remember Iron Man. We know the character and it says iron since we're dealing with iron deficiency. There are others, Affirm, Acute HF, and others, but okay, yes. So class 1 recommendation with level of evidence B, so there's multiple randomized control trials, to give in intravenous iron supplementation is recommended in symptomatic patients with HFrEF and HFmrEF and iron deficiency to alleviate heart failure symptoms and improve quality of life. So a mortality benefit wasn't very clear, but it improves symptoms, it improves quality of life. And intravenous iron, either iron carboxymaltose, or in the Ironman trial, they used iron derisomaltose. So, okay, so class 2A to use intravenous iron supplementation with carboxymaltose or ferric derisomaltose should be considered in symptomatic patients with HFrEF, HFmrEF, and iron deficient to reduce risk of heart failure and hospitalization. So give them iron, intravenous iron. The clearest evidence is that it improves quality of life and helps to alleviate symptoms, but it may also improve hospitalization. But that is why this is a 2A. It may improve hospitalization, is not as clear. So these are the main additions. So I'll go over them using SGLT2 inhibitors in HFmrEF and HFpEF, class 1 in recommendation now. Rapid up titration and intensive therapy with the GDMT after admission for acute, when a patient is admitted for acute HF, and before discharge, and frequent follow-up to reach target doses as much as possible within 6 weeks, while ruling out contraindications and close monitoring of heart rate, blood pressure, potassium, plus electrolytes, renal function, congestion, and symptoms. Oh dear. Let me put it back. Okay. And then iron supplementation. So other things that yes, so again, sorry, I think this should be probably second to the last point. In acute heart failure, earlier people were trying to look at use of other diuretics in addition to loop diuretics. Yesterday, when we talked about advanced heart failure, we saw that we could add metolazone or thiazide. So there are people who have tried to study whether we could use acetazolamide. They did not put up like a recommendation table in the update as for other guidelines, but let me just read the concluding statement. Although results from some trials, there's one, is it ADVOR trial, may support, if you can see my cursor in case you want to follow, may support the addition of acetazolamide to standard diuretic regimen to aid decongestion. Further data on safety is needed. So apparently it had some benefit in reducing congestion, but there are concerns about safety. Then this chlorotic trial looked at adding hydrochlorothiazide, oral HCT, to in addition to furosemide, again for patients to aid rapid decongestion. And there was not much, so see, changes in reported dyspnea were similar between the groups that received HCT and those that did not. Serum creatinine increased more frequently in those that received HCT. Rates of hospitalization and all-cause death were similar. So the lack of an impact on clinical outcomes precludes any recommendation in the current guideline update for use of HCT in addition to loop diuretics to for the purpose of treating congestion. So I think that should be the main additions I have. Just give me a second. I want to check something. Okay, let me just share the main ESC 2021 guideline. There's a slight thing I want to show. Because I hope we're still awake. Are you with me?
Yeah, I am with
Okay.
you. I know the others
Okay.
are.
Okay.
Eji, let's hear you now. Good evening, sir. So that I will be sure I'm not the only one that is there.
Abio.
Dr. Florence, let's hear your sweet voice, ma'am.
Good evening. Sorry, I've been in and out. There is nothing like something
Thank you, ma. It's confirmed they are here.
Okay.
Chief,
Okay. Just like you.
Chief Odoye,
Really.
Dr.
you
Brown.
said what?
No, we were just checking on you, ma.
Oh, okay, that's so cool.
Yeah. Chief Odoye. Okay. They've responded in the chat box. They are here, ma. So it's confirmed.
Okay.
Thank you.
Okay. Thank you. I just wanted to confirm I wasn't speaking to, Zoom does that to you. You wonder if you're, so I found, okay, so it's coming up. Can we see this? This is I want to enlarge. Yes, okay. It's going to enlarge now. Okay, so this is just at the beginning of the 2021 guideline and a comparison of the 2016 and 2021 and some of the things that were bumped up to have a higher recommendation. I just saw this and I was like, So we know that if we have, like we were just shown, complete left bundle branch morphology with symptoms, symptomatic patients with ejection fraction less than 35 and QRS duration 130 to 149, so less than 150 or greater than 130 is a class 2A recommendation. Despite optical medical therapy, I'm seeing a promotion to class 1 here. I'm not sure this is widely known, so maybe we can just stick to saying is a class 2A and then greater than 150 is a class 1 recommendation. But should we ask, has there been an upgrade? Do you know what is the latest? You can say, well, okay, the ESC decided to give QRS duration 130 to 149 a higher recommendation.
Dr. Ruki, I can't hear you again, ma'am. I don't know whether I'm the only one. Dr. Malade, can you still hear?
It has history of risk factors, then we should do like serial cardiac evaluation, including global longitudinal strain. Oh dear, my network. Sorry, my network just fluctuated. The
Yes,
laptop, yes, the
okay.
laptop just connected. Let me put it back.
Okay, ma'am. Thank you.
Okay, it has reconnected. Let me put it back. Okay. So here, earlier when, we found DOACs or NOACs to have very good, like they were as effective as vitamin K antagonist warfarin for non-valvular AF, with less risk of bleeding, easy administration, blah, blah. So in the 2016, what we, was that we should use DOACs over vitamin K antagonists in patients with heart failure, except when we have valvular AF. But they kind of changed it a bit to say that patients with heart failure and non-valvular AF should have anticoagulation based on the CHA2DS2-VASc score, and we should consider using NOACs first because of, I don't know, it was downgraded to a 2A. Again, we see that when we have atrial fibrillation, we should consider, recommended giving beta blockers kind of as first line for rate control. Revascularization, that was extensively discussed with Dr. Malade. If there is need for, if indicated, so we have persistent heart failure in a person with ischemic heart disease, use of SGLT2 in patients with type 2 diabetes, whether or not they have heart failure, to prevent or delay the onset of heart failure and improve outcomes. I think this is where I'm going to stop. It's 9:05. I think we have really tried.
Wow. Excellent presentations. Thank you so much, Dr. Oruki. Thank you once again, Dr. Imalade. It has been an exciting, excellent and stuffy day. I don't know. Is there any additional comments, questions? Dr. Oruki, you mentioned lung ultrasound. I also don't think it's in the guideline, but
Yeah.
there have been studies and trials that have really said that it's highly specific. So it's likely that maybe when the next guideline comes out, they might be talking about it, or it might be there.
Yes, possibly.
Yes. So please, we welcome additional comments and contributions from everyone so that we can end the class, go and do other things.
Okay, sorry, let me just talk about influenza and pneumococcal vaccines, please. Class 2A recommendation. And really, they are very frequent. I presented my study yesterday. Respiratory tract infection was the most frequent precipitant, And I think even so, the world over, it is relevant, even if it is not the most frequent. I think in the developed countries, probably ACS might come first, but it's relevant. So pneumococcal and influenza vaccines, and some of the trials that supported this include the influenza vaccine for something prevention, which had centers in Nigeria. I know my center participated in the IPP trial. We're busy recruiting, helping to identify patients, registrars. I think other centers in the country as well. Then exercise, cardiac rehabilitation. Sorry, I even wrote it down on my jotter to emphasize that the need for supervised exercise therapy to prognosticate, but also to improve, like to prevent cardiac deconditioning. So patients who are likely to become frail, have comorbidities and all that, to encourage them to move and all of that, we should have supervised exercise cardiac rehabilitation. And this supervised exercise has been very relevant in many cardiovascular diseases, including peripheral artery disease, actually. Okay. Sorry to still say more. I think let me stop here.
Any more things, Dr. Ruki?
No, I think that's fine.
Thank you very much.
I think you're okay. You were talking about pneumococcal vaccination. Against what? For what condition, please?
Okay, as part of adjunctive therapy or whatever for heart failure, we should give them vaccinations against respiratory tract infections. So influenza for the common viral infections and pneumococcal vaccination. I'm looking for the place again. So to
Now, this is
prevent,
triggers for the compensation, is it?
respiratory, sir?
Are there triggers for the compensation or what?
Yes, they are. So respiratory tract infections are triggers for decompensation. So pneumococcal vaccination and yes, this is where it is. And influenza vaccination should be considered because if they trigger decompensation, then they cause the patient to need hospitalization. We know hospitalization is a poor prognostic, factor in heart failure. The more hospitalization, the worse the prognosis.
All right, thank you.
Thank you.
Yes, in addition to that, so I think there are also triggers to ACS.
Oh, okay.
Then I think there's one more thing. I did a presentation some while ago. Well, there is ACS, MI, embolic events.
Okay.
So I'm advocating for giving all those vaccines for patients with heart failure and other comorbidities.
Thank you for the addition. I didn't know they had a role in ACS.
They do. Then another thing I want to mention is that I'm just preempting or suspecting that they might think that we should discuss about cardiac rehabilitation. So I just want to encourage everyone to just go and look at the steps, the phases. It could just be one of the questions in the exam, so that we get ourselves attuned with it.
Sorry, steps of what, please?
Cardiac rehabilitation.
Oh, thank you.
Yeah. This thing, as in it just came to my mind over and over.
Thank you for sharing it. Sometimes you are receiving grace, Abby.
I don't know.
Yes.
Oh,
yeah, well, sometimes something odd just pops in. I think it's good to just have a look at it in case.
Even if it won't come out eventually, but if it now comes out, that will be very bad.
Yes, you want to see truly. Thank you.
Yeah. Thank you very much, ma'am. I don't know whether there are additional comments, contributions. Prof is there. Prof, good evening, sir. Hello, Prof.
Good evening. I'm just reading. I just saw one comment posted on the platform, and I said, "What's that?" Was good. It's fantastic collaboration.
We are glad to have you, sir.
Thank you, sir.
I should just check.
So, any additions, sir?
No, at first I just reasoning and I'm seeing nice presentation. So it's not as if I knew what was happening before.
Okay, we're reviewing the heart failure guidelines, the current heart failure guidelines.
Fantastic. God bless everyone.
Amen.
Amen. Thank you, sir. Please, chiefs, any other addition, contribution?
Brain juice is finished.
Oh, Dr. Ruki, leave that brain juice. So, in the absence of further comments or contributions, I want to sincerely thank everyone that have discussed today, and I want to thank everybody for turning up. I wish that we made these decisions earlier, but it's still good. It's not too late. We keep trying our best, and we keep praying for our management board and everybody, so that they are very, very busy. So, but I keep, Prof, we need you around, sir. I keep telling every one of them that we need them around so that at least they can guide us in what to do. Prof is here this evening. I don't know, can we still do the quiz tonight? Or we should go and rest and do it tomorrow? Dr. Ruki, Dr. Prince,
I think we can do that tomorrow.
Dr. Prince, why not tonight? Why tomorrow?
Well, I'm thinking that, I mean, that was probably one of the reasons we closed early, so that subsequently we'll be able to finish up with the schedule ahead of the week, because once you get to Monday, you have work, other things coming till Friday. So I'm thinking that if we decided to have close early, then the reason why we close early is probably for us to get wine of what is left. So if we are having the quiz, then we might as well just probably have closed around 12 like we used to do. Then we didn't have any time at all. I mean, that's my thoughts anyways.
Thank you for sharing your thoughts.
Mm.
But it's not guaranteed that tomorrow too will not be busy, but it's whatever we all agree on.
I mean,
Please look
tomorrow,
at the flowers comment.
Oh, the
for
quiz
tomorrow,
is the month